Hi, everybody. My name's Dr. Sofia Noori, and I am the Chief Resident of Digital Psychiatry at Yale Department of Psychiatry. I feel very honored to have been invited by Dr. Becky Inkster to give you a talk about my experiences as a frontline psychiatrist providing care during the pandemic. So a little bit more about me. I am the Chief Resident of Digital Psychiatry at Yale. So this is actually the first time this position has been offered in our department. And my role is to develop education and clinical training opportunities for residents to learn more about digital psychiatry and to be trained in it. I'm also a founding member of the Center for Digital Psychiatry at the Connecticut Mental Health Center, which is a role I'll talk about in a little bit. And then I also trained, I got my MD at the University of California, San Francisco School of Medicine in a special program called Prime US, which is a program that trains students interested in urban underserved care and offers a dual degree. And then I also have some experience working in digital health. So I've worked in multiple startups, and I currently develop curriculum for a substance use entrepreneurship program called Innovation to Impact, which is also here at Yale. So I want to talk a little bit about where I trained in the last year. So I was working in outpatient psychiatry at the Connecticut Mental Health Center, which is a safety net mental health center in New Haven, Connecticut, which is located about 110 kilometers from New York City. And CMHC is a really special place, near and dear to my heart. And one of the reasons why it is because we actually have state government funding to provide care to people who otherwise wouldn't receive care, including undocumented patients, uninsured patients, homeless patients, recently incarcerated people, which is really, really cool and something that's not standard in the United States. So many states don't have dedicated funding for this, and these types of populations just go untreated. So it's been a real privilege and honor to be able to care for them. CMHC is also really cool because we have a lot of different types of treatments. So we have outpatient treatment, inpatient treatment, substance use treatment. We also have an in-house pharmacy. So patients who aren't able to get their meds filled at other pharmacies because they can't afford it can actually get their meds free from us. And also it's a partnership between the state and Yale Department of Psychiatry. So there's employees who are state employed, and also there's staff who are Yale employed. But as you can imagine, CMHC is not really a revenue generating entity, right? Because so many of our patients are not able to pay. And because of that, we are always on the chopping block and when it comes to the state's annual budget. Every year, we're concerned that the budget for CMHC will be cut. And because of that, there hasn't been that much of an investment in some of our infrastructure, specifically our tech infrastructure. So we actually still use paper charts. We do have an EMR, but the EMR is chosen by the state government. And unfortunately, our EMR doesn't work for all the note types that we use. So we still actually have the paper chart. And we just implemented e-prescribing 12 months ago. So that just gives you a sense of how we adopt technology in the center. So despite, the fact that we have some issues with our tech infrastructure as a center, there has been a recognition that, our patients use technology in a different way, and there may be creative ways to infuse technology in their care. So the CEO of the center, Dr. Michael Cerniak, some faculty and residents and I launched the Center for Digital Psychiatry at CMHC with the goal of trying to understand how to evaluate and also implement digital health technologies in the care of our patients with serious mental illness. So as we were trying to figure out what would be the first steps in terms of implementing this goal, we realized that we don't really understand how patients use technology at the center. And so one of the first things we wanted to do is just to figure that out. So we looked for different types of resources, and we came upon this DOORS manual, which is that came out of John Torres's Division of Digital Psychiatry at Beth Israel in Boston, Massachusetts. And they came up with a 4-part patient group to kind of understand how patients are using their smartphone, but then also to teach patients how to assess apps and also how to use a basic digital health app. And we thought this was really cool because it's actually, the patient manual is designed for patients with serious mental illness. So what better way of figuring this out than using something that's already been implemented and been designed and trying to lay it all out at our center too. So we called our patient group that was using the doors manual Tea and Technology, which was like a little cheeky name. And we also gave, we had tea and cookies during the patient group as well. And it was super interesting, and our experience with the group was unexpected, actually. During the first group, which we implemented in December of 2019, we realized actually that our patients have much lower tech literacy than we thought of. We thought that pretty much everybody has smartphones right now, that our patients would definitely have less adoption, but would still have some literacy with using phones. But what actually ended up happening is we found out that like some of our patients don't even know how to turn the phone on. Um, they had family members who were turning the phone on for them and charging it for them. And so they couldn't even identify the charger, the appropriate charger for their phone. And most people, the only function that they knew how to use on their phone was the dialing function. They couldn't use any other apps or any other features on the phone. So we actually spent we actually had to totally redesign the patient group and just spend it very slowly, just introducing people to how to use a phone, a cell phone. That the group ended in January of 2019. So after the group ended, and it was a pilot, so it was really informative, we tried to figure out what should we do next, because we're realizing that our patients have a much lower understanding of how to use phones, and what would be most helpful. Like, would it actually, maybe what would be most helpful is just teaching people how to use their phones. So then what we tried to do was we tried out a geek squad kind of approach, where literally we would bring chargers, set up a charging station in the cafeteria of CMHC, and we would just sit there and talk to people as they came up to us and ask them, like, have you ever had trouble with your phones? Is there something we can help with? And we were just implementing that in February of 2020 when COVID hit. So as we all now know, like, New York City became a huge global epicenter for the coronavirus pandemic, and we were not far away. Connecticut ended up having 40 to 50,000 cases of coronavirus, and essentially CMHC had to transition to remote work, which, as you can imagine, for a place that has paper charts, was pretty hard. So what ended up happening was, we essentially went dark for a little while. Like, our groups ended. Our outpatient visits all had to be phone based or video based, and then our IT team had to scramble to get us remote access to our EMR, which we did not have remote access before. So that took a while too. And then another complicating factor of all of this is that we had never anticipated ever needing to work remotely and virtually before. So the state government had not selected a telehealth vendor for us. And this picture just illustrates that, the state government chose Microsoft Teams and approved Microsoft Teams for use on May 7th, 2020, 8 weeks after we had to transition to remote work. So what ended up happening was that because the state employees were not approved to use a telehealth software, the Yale employees, who were not necessarily under the same stipulations, had to find and stitch together like a telehealth solutions to do so. So we used Zoom for that. Yale has a business account for Zoom, so we were able to use that. A lot of people use Doximity Dialer, which is a free function where you can dial and also have video-based visits with people. And then I personally also used OMD, which is a texting app where you can send HIPAA-compliant text messages to patients. And now we also had to use all free solutions because there was no funding for this. In implementing all of this, we learned a lot of really valuable lessons, and it was a bumpy ride. So we were scrambling to connect with people in any way that we could, and we were just figuring out how little literacy our patients had around using their phones, right? So even though we had Zoom, we couldn't Zoom with a lot of patients because they didn't understand how to video conference or they didn't have a smartphone. Some of our patients didn't have a phone, period. And so it was really hard to get into contact with people, or that we would have to coordinate with their family members to make sure a family member who had a phone was with them so that we could call. We also realized as well that there's not only a digital divide with our patients, and when I say digital divide, I mean that there is a subset of the population, as the patients of CMHC are, who do not have access to smartphones and computers. What we realized is that the digital divide also applies to staff in some ways as well, because the staff they were never charged with learning about how to do telehealth before, right? So some of them had never even used Zoom as well themselves. So there was also a steep learning curve for the staff to get tech literate with some of these softwares, to be able to provide the care to the patients. And so what ended up happening is we essentially tried to provide care however we could, whether or not that was through the phone or just still in person. One of the things that actually also happened was we realized that people were having trouble getting their meds, because our population has a lot of people who are very high risk for getting COVID, and they don't have cars and they don't have private transportation, right? So they're taking the bus to go to the pharmacy and exposing themselves on their journey to get the meds. So we basically just did everything that we could to help people, like anything and everything. So one of the things that some of the residents and I did was we just like basically launched our own little delivery service for people to receive their medications, and we would pick up their prescriptions and give it to them, because our pharmacy doesn't have that capability. So that was something that we just needed to figure out and just do on the fly. For our patients who could navigate their smartphones, we also compiled a list of free and low-cost mental health resources online that people could use. So this was intended for clinicians to recommend different services to their patients, because all of our groups were shut down. So some of the things that we learned from this incredible journey is that, you know, the role of technology is completely different now that COVID has hit. And there was also not a lot of investment in tech infrastructure before this. And I think being a late adopter of tech infrastructure at our institution and in our government really hurts underserved populations, because underserved populations are the ones who are usually on some sort of state-based or state-funded healthcare, and they're the ones that feel the brunt of this like late adoption of tech infrastructure, as we saw. And this contrasts with another hospital that I've worked at, Yale New Haven Hospital, which does have Epic. They were able to transition to remote work and to virtual care within a few weeks. You know, they were at 100% virtual care visits. Whereas for us, it was difficult because we didn't have that infrastructure to begin with. And it's unfortunate that it may have affected what we were able to provide our patients during the transition. Also, I think it was really important that we just meet people where they are, and including with their abilities with technology. And sometimes that means that we literally just need to do things in person still, right? Like we just need to visit them at home. I had to do that a couple times, just go on home visits, see how people are doing, or deliver their medications in person. And I think that this also forebodes a couple trends that we'll see in digital health. I think home visits are still a valuable component of care that could make a comeback. I also think that technologies like text-based and phone-based technologies could potentially be more effective for underserved populations, because that's what they are best suited to use right now. And I will say that with our online mental health resource guide, I personally recommended the phone-based groups more than any other service or app that was on that list. And I also think that, you know, we've approached technology as an administrative issue, right? Like our healthcare administrators and our state administrators picked the software, but it's actually a health issue. And we're starting to realize that more, that, you know, if, for example, with students now, right, like they have to move to, now school is becoming remote, and we're realizing that there's people that don't have internet or computers, right? Like, for example, our mayor, he sends COVID-19 updates by email and by text, and there's guidance in there about what to do and where to get tested. And if you don't have an email, or if you don't have a phone number, you're not getting those updates. And this applies to us too. We realize that the technology that we use has a fundamental impact on the care that we deliver to people. And I think that we're going to see a shift in how people think about technology in healthcare, that it's not an administrator level issue anymore. Like it's an issue that all of us are affected by, and it's becoming a clinical issue. So looking forward, we're still in the thick of this pandemic. CMHC is still transitioning to remote work and getting everything up online. And we're now starting to think with the Center for Digital Psychiatry and as people taking care of patients, how do we reflect on this process and how do we improve for the future if this, God forbid, were to happen again, or if we had to do this again? And also, how can other people learn from our journey? I think this talk is a part of that opportunity, and we are reflecting as a center in general, and how can we do this better for the future? So there's a lot to be learned there. And if you're interested in the work that CMHC is doing, I encourage you to go to cmhcfoundation.org. If you're interested in donating to our cause, please do so. There's a lot more that I could discuss around this topic, and this could go on for a much longer talk, but we have to end it. If you're interested in talking more about this, please feel free to email me or find me on Twitter. And I'm really grateful to have had the opportunity to talk with you about this. And also, I just want to underline again that it was, despite the rockiness of remote work and the pandemic, it was such an honor to take care of the patients that we took care of at CMHC. And it was a life-changing experience for me. And I'm so grateful that I had that opportunity. Thank you again for allowing me to talk, and be well, be safe.